We are so excited to be here with you guys today.
As am I. And, you know, all politics is local, and we are actually also going to talk about some policy, which is the thing that politics is the framework to help develop. It doesn't always work in our country, but we're super excited to be here today.
And I think Phil really pointed out what is so true, and Jay just echoed that what we do to represent ourselves locally is being doctors in our clinic, building those health plans for our communities based on our community's needs. And we are going to try to reframe that and elevate what you're doing and talk about it as to how it has made a difference on the national level.
So we thought we'd just start really quickly with a little bit about where we've been and where we are now. When Dr. Garrison Bliss contacted me sometime as the Affordable Care Act was coming together and said, you know, we got to do something about this Affordable Care Act in Washington, D.C., because not that it's a bad idea, but they're going to put all of the primary care through insurance. And we don't do primary care in insurance, and we do it a whole lot better. And so we said, you know, do we have a story to tell that says there's a lot more people doing this, or there's a lot of people doing this? And back in 2009, I think we managed to find about 100 clinics around the country that were doing it. We put them together and asked them if they'd be on a letterhead for the Direct Primary Care Coalition. Here we are, just a few years later, and there are over 2,500 DPC clinics, over 1 million lives in DPC. There are practices with, candidly, close to 500,000 that are technically DPC practices, and there are practices that maybe have 40, 50, 60 patients, and everything in between. So there's been a lot of progress that's been made, and a lot of it has been done with a number of regulatory hurdles that are still in place. And so we'll go over a little bit about that, and then talk about, you know, two things, you know, it's like where we are now and how can you get involved.
Absolutely. So our next slide shows the ever so famous map that Dr. Filescu, MD, DO, and MBA has put together, and we've all contributed to, because this is the DPC mapper. This mapper, I remember in 2019, sitting in San Francisco at the HINT Summit, was sparse. There were little dots. And in 2024, to say there's over 2,500 DPC practices, and that's not even counting direct specialty care. This is an incredible time to be in healthcare, and we are on the right side of history. So many people love DPC, clearly. We all love DPC. But patients love DPC, and they buy into what we're bringing. Some people might think it's voodoo medicine, but we are bringing old-fashioned primary care to our patients for affordable rates. We're making it accessible so that employers can bring it to the patients as well. But it is incredible to see, and the people who are physicians in this room, the people who are building these health plans for self-funded, direct primary care centered plans, we know the stories, and each and every one of those stories represents how each one of our patients loves the relationship that they have with their DPC doctor differently, because everybody perceives and receives healthcare differently. And when you personalize your healthcare option, this is what happens. The movement grows like wildfire.
And I was so excited to see the first panel that was really talking about how do we validate that? How do we show this? And we've worked really closely with Fritz Busch at Milliman and Rebecca Etz on the patient-centered primary care measures to try to bring the data to bear. And what we've pretty consistently found since back in the day when Garrison and Erica Bliss and I were working on the first data set is that, you know, employers have shown up to a 20% savings off the total cost of care for a benefit that on top of the regular PPO or insurance benefit includes a DPC membership. And that has really caught on. Since we put the provision in the Affordable Care Act that essentially says that DPC is not insurance, it's a health plan, and it can be a part of the essential health benefits working in conjunction with insurance, we've managed to pass laws in now 34 states. The most recent was passed just a few weeks ago in Alaska. And these laws all in one way, shape, or form say that DPC is not in fact insurance. It is not a health plan, which have different definitions in the tax code and some different parts of state laws. And the Affordable Care Act provision, which was the first place that the words direct primary care were ever written down in statute anywhere, essentially agrees with that. It says, these are primary care services. They're appropriately regulated by state medical boards like any other practice of primary care. They're not insurance schemes. They're not health plans. They are primary care services. So, you know, we talked a lot about how dysfunctional, Phil did a great job setting us up here, about how dysfunctional our politics is today. I mean, think about how many healthcare issues there are that are out there that have the support of being in the Affordable Care Act in the Obama administration, have been supported through the Trump administration with demonstrations on direct contracting with physicians, and have carried on into the current administration, albeit in a very different kind of manner than most of you are used to practicing, in the ACO REACH program. So, you know, we've not only had the attention of legislators around the country, members of Congress in Washington, but we've had the attention of Medicare, Medicaid, CMS. States are asking CMS, how can we get a piece of this direct primary care to help fix our Medicaid program? So we're working on a number of pieces of legislation, you know, that are going to address that. I'll take a step back. Again, this is a slide that just sort of talks about what is the provision in the Affordable Care Act. And these are the sites, and you'll be able to get these slides, so we won't spend a ton of time on this, but the reality is this provision really set forth at least 33 of the other state laws. Garrison passed the one before the ACA that was the original state law that says this is not insurance, it's not regulated by the insurance commissioner, as long as you're following these certain rules. It is the business of medicine, not the business of insurance. These rules were carried over into the Affordable Care Act regulations, and if you can look up the site here, it cites it right back to the Washington Code. It says that these are primary care practices, they're not insurance. And so for the first, it's like 10 years of our effort, it really was about making DPC legal, making it so that the insurance commissioner wasn't going to knock on your door and shut you down because you're doing the business of insurance without a license and without all the sort of capitalization that comes through that. As I mentioned, Medicare has taken a good look at doing this. When the Trump administration was getting ready to put together this direct contracting program, they called the Direct Primary Care Coalition, and some of you in this room joined us in this effort. We flew around the country and we did focus groups with people that were doing direct primary care, and with people that were doing fee-for-service, and the people that were involved in some of the value-based ACOs that were happening at the time. And what CMS found was that there were pretty dramatic differences between the level of satisfaction and happiness of the physicians in the one room that was doing DPC versus the level of satisfaction of the ACO physicians, which might have been a little bit better, but then you had the Stockholm Syndrome fee-for-service crowd that really just couldn't wait to get out of the room. So that's really caught on. So we're going to talk a little bit about a fly-in that we just had. Maryal was there, and we had a bunch of people in town, but it was a game changer because we've spent 10 years trying to just make direct primary care legal. And now we're working on the future. How do we grow the movement? How do we clear the hurdles and try to make sure, for instance, that your direct primary care practice doesn't make you ineligible to fund an HSA if you happen to have a high deductible health plan paired with an HSA? That's been a major hurdle we've been working on for a long time. The good news is, with the help of this gentleman right here, that's Earl Blumenauer. Earl is a senior Ways and Means Committee member who's been a major long-term champion of direct primary care. His bill that he's co-sponsored with Senator Bill Cassidy, a Republican senator from the state of Louisiana, who is also a physician. He's a gastroenterologist, so he's not a primary care doctor, but he realizes that this is a great idea to make sure that people that have these, that are paying these high deductible fees to be a part of these plans can use their HSA and have a DPC plan, whether or not they have the HSA. And so, you know, we have Earl Blumenauer out there pushing as one of his very last things that he wants to do before he retires from Congress to get this bill done. We have passed the bill out of the Ways and Means Committee in a bipartisan vote, in a stunning bipartisan vote, in a time when we really haven't had a whole lot of bipartisan votes. And so we're working on a couple of other efforts beyond getting it in Medicare, Medicaid. So the Medicaid Primary Care Improvement Act would allow states to work with CMS, the Medicare agency, the Medicaid agency, to ensure that the state can figure out a way to do direct primary care in that state. As you know, the Medicaid agencies are operated by their states independently, and they write the rules for their program, but they get federal funding. So this would create a rubric for which we can have a dialogue that would include DPC physicians, the carriers that are in the Medicaid managed care plans back in the state, and most importantly, the lessons we've learned from where we've been in Medicaid before, having the state have a seat at the table with the federal government and the managed care companies to make sure that it's done right. Dan Crenshaw from Texas, again, an example of the bipartisanship of this, is a lead sponsor of this bill and is really pushing it as a way to get better primary care to low-income people in Texas. And he's joined by Kim Schreier, another physician from the state of Washington. These two folks are wonderful people. We really love working with them. They don't agree on almost anything. What they do agree on is that whether you're the CEO of a company, whether you're an individual small business person, whether you're unemployed, whether you're on Medicaid, whether you're an FQHC, or whether you go to the fanciest hospital in America, you should get your front line of primary care from your personal primary care doctor that's paid with a monthly fee and not in the fee-for-service hamster wheel.
And going back to what Philip Boucher said, you know, the call out that things are pretty divisive when it comes to politics. Amazing examples of bills that are truly bipartisan. This is where bipartisanship is so, you know, needed, but this is where I will point out Dr. Kim Schreier, our stories matter. And when I say Dr. Kim Schreier, she is a pediatrician. She is in Seattle. It was because of talking with Dr. Garrison Bliss and hearing how not a single one of his patients died during the pandemic because they had access to his care for an affordable rate with no barriers to, is that covered? She leaned in even further. And so this is how a local story in Seattle blossomed into what is a bill that is bipartisan on the Hill.
Not only is it a bipartisan bill, it is a bill that passed the United States House of Representatives unanimously in March of this year. So we're in an end game right now. You probably all know there's an election coming up. Anybody care to guess what's going to happen? No, don't answer that question. Nobody knows what's going to happen. What will happen is that next year, Congress will be a very different place. There were a lot of retirements this year. I think it quite possible that we'll flip from where it is now. Right now, the Democrats control the Senate. The Republicans control the House. Looking maybe like the Republicans, regardless of what happens, the presidential level might actually take the Senate, but they might actually lose the House. So things are very tight. The margins are very, very close. So there's a number of things that need to be done by the end of this year in what we call a lame duck session of Congress. For one, at the end of the year, all of those COVID-era exceptions for the provision of telehealth expire. So basically, you won't be able to do telehealth using the codes that were put in place and all of that sort of thing. Well, we've gone to Capitol Hill and talked an awful lot about how during COVID, Dr. Bliss and all of you who do DPC, they didn't need any special codes. You know, their patients didn't go to see them in the clinic. They picked up the phone and called. Or they used the Spruce app to connect with their doctor to have a conversation about their primary care. Didn't walk into the clinic, get anybody sick. So again, how do we get this into Medicaid? And when I say that, and how do we get it into Medicare? We've had a deep conversation with the Senate Finance Committee in the past year about perhaps moving away from the MIPS model of measurement in fee-for-service and going to, oh, wouldn't it be a good idea maybe if we just paid the primary care doctors a monthly fee with a single payment code and just let them do what they did and don't worry about all of this reporting and all of this other stuff. Like, hey, that's a brilliant idea. Why don't we do that? May or may not be called direct primary care. We're working on trying to make sure that as these things move through Congress, your voice is heard. Now, I'm not bad. I can do a pretty good job at that. I'm not a doctor. I did sleep at a Holiday Inn Express. So, but what we really need are these voices here and this voice here. And to come to Washington, work with the Direct Primary Care Coalition to tell your story is the absolute most important thing to do. And one of the first things Maryal will tell you that I say to people as we're getting ready to go to these offices, don't get mired down into what HR 3836 does and whether or not it includes a monthly fee and a shared savings arrangement and this, that, and the other thing. Go in there and tell your story. You know what the first question I usually get from a lawmaker when I walk into the office and talk about DPC? Anybody hazard a guess what the first question I get from a lawmaker is? No. How do I get this?
And it was quite, on that note, Dan Crenshaw said when we were meeting with him that as representatives, as senators, they have access to direct primary care with the House physician. They can have a BUCA plan, but they can also pay a fee to their doctor directly to get DPC on Capitol Hill.
So all members of Congress do actually have access to DPC in a, it's not really called that, but it's in a funky little way. And it's a discrete charge that's taken out of the representative's office on a monthly basis that pays the House physician. So, you know, there's a long history of this as a model that some of these members really do understand. Getting the details right is really, really important. We just spent 3 days on Capitol Hill. We met with Senator Bill Cassidy, Representative Earl Blumenauer. Not only did we meet with them, they came to us, which is, you know, really quite nice, you know, when the member of Congress isn't asking you to go to their office, but they're coming to yours to talk to the folks about what's going on. And I think that we've left the era where we had to explain what is DPC quite a while ago. People get it. Then we went through COVID and we proved the concept. We mentioned that site of employers saving about 20% of the total cost of care, which kind of comes from the Millman study and some other data that's out there. The direct contracting model that IORA did under Dr. Ruchika Fernandopulle actually saved CMS 21.4% when they were doing it. And I'll be the first to admit that, and Ruchika would be the first to admit, that's not exactly DPC, but even this sort of like muddied up version of DPC that's way better than an ACO and way better than primary care, there's no other demonstration CMS has ever done that saved 20% of the total cost of care. They don't even come close. The highest performing ACOs out there, if my memory serves me correctly, and Fritz Bush or somebody else might correct me, maybe 5–7% savings. And that's maybe a handful that candidly, even though they're not in the DPC model, are treating their patients the way you treat your patients. MedPAC did a study, and this is the congressionally mandated organization that studies Medicare, and what they found was that the key to getting savings in an ACO was, guess what? A relationship with a doctor that went over years, not over weeks or not over months. That the relationship is where the stickiness happens, that creates the good health, that then creates the savings for things like Medicare or people like employers or people like your household.
And it really highlights how these are the ears that we are talking to are interested in savings and not how much money can we make off of how many codes a doctor can process a day. So these doctors, many of whom are in the room, some of whom have spoken already today, this is because they said, hey, I have a story to tell. I have a CEO of a million-dollar company sitting in my waiting room across from someone who works at McDonald's, and I give them the exact same care. These people were able to share how DPC is being delivered in a nonprofit way. These people have been able to point out how they stayed in their community and their community did not lose access to health care because direct primary care exists. And because we were able to collectively, over time, and this is something coming from Dr. Garrison Bliss and Jay, hearing them say that the transition really has happened since they started pounding the pavement to say, what is DPC? And now the staffers instead are, I know we're supposed to be done with time, but come on, keep talking because I still have more questions. Or, we're gonna make sure we follow up with you, not give us your card, please follow up with us. It's an amazing place to be, again, in healthcare, but we have to take advantage of that. So definitely, we want everybody there on Capitol Hill. It's not just physicians. Zach was there. He was our bodyguard / lobbyist, in February. It's fantastic. We are able to bring the stories in whatever industry we are working in to say, we are already doing it right, and this is how you can help us do that. So these are the two bills that we are bringing to the table. That we are lobbying for, I should say. And it's incredible too, as Jay mentioned, we are about to close out Congress and the momentum of all of these bills trying to hit the finish line is there, but two of those bills that have this grand momentum are focused around direct primary care. Congress loves it, we love it, because direct primary care is pro-physician, direct primary care is bipartisan, and direct primary care is pro-patient.
Boy, I don't know whether I can top that. So, I think we have a few minutes to take some questions. We're happy to take some questions from the audience. Got one right.
So the question was, or the statement, the fact of truth there was, California is not yet on that map. That is correct. A bunch of the doctors who you saw on the screens, as well as myself, are working towards sharing our stories to change that in California. Because we do have, we live in the nation state of California with our own little special laws, and we are addressing that by, just to speak to how we're doing it, because I know this crowd loves nuts and bolts, is we have become engaged with California Academy of Family Practice. We have said and pointed out, the experience from an independent, non-insurance accepting doctor is very different. Let me share with you. And if that voice is not at the table, you end up with what we have now. And this perpetually continues. I got in contact with Jay because my husband, who is a family practice doctor, his role got eliminated. So the only two physicians in our county, in Northern California, who can see you if you're pregnant, if you need a procedure, et cetera, is a full scope family doctor, and the only two in the entire county for the last almost 10 years have been myself and my husband. When I was able to transition, and when he lost his role, he was able to transition. And our community doesn't have access to a full scope doctor if they wish to use their insurance. And that is what Jay encouraged me to tell as my story. And so this is where, when I'm telling my colleagues at the California Academy of Family Practice, a lot of them are like, blank, I literally don't understand what language you are speaking. And then the others are, but you didn't leave. How is this possible? And you're smiling. How is that possible?
California is a particularly complex state because there are really three parts of the code that would have to be cracked to clarify which is really the existing regulatory regime, which is DPC is okay. There's Knox-Keene, which governs managed care plans. There's an entire set of HMO statutes, and then there are other insurance titles. So in states where it's a really tough fight, you might not want to, like with California, it's the golden bear. You don't want to poke the bear too much if there isn't a necessity. So the states that aren't on the green in the map are either states where there's not a real problem in the code, or states where there might be a problem and it would be a good idea to clarify it, but that might be a long fight that we might have other battles to fight first. So I don't really anticipate there's going to be a ton of more efforts on this define DPC as non-insurance because, candidly, everybody gets that. And in states where it's poorly defined in the law, they're not really enforcing it. So we can't take that to the bank, but it is maybe save your ammunition for another day, right?
We have a question here on the left.
Hi, Deb Moore from Amarillo, MD, 8.5 years now, and I really am interested in helping with the policy, and I enjoy doing that. I really enjoy telling stories about how patients are taken care of, but I'm not, one of those legislation-versed doctors. So I'm hoping I'm speaking for a lot of the physicians in the room. Is my head is exploding with business acumen that I'm learning, and growth and all of those things, and so I just really want you to tell me what I need to do, and I'll come and do it with you.
Yep.
So that's number one. And then number two is we have this problem in Texas that we're trying to work on with dispensing. Yeah. And I was told that the pharmacy, I guess the Pharmacy Association is kind of holding us hostage in because they want us to give pharmacists the ability to test and treat, and so they won't give us the ability to dispense until we give them that ability. I don't understand all of the ins and outs of that, but if there's any doctors in Texas that want to work on that with me, and I could get some counsel, then.
That is a top issue we're working on right now. So in addition to these state non-insurance laws, we're working on a number of other issues. Ken talked about a few of them this morning that would allow your DPC payment to go towards your deductible, and some other things. We're also working on some rules that would say, hey, if you're a licensed physician, you can refer to anybody as a specialist, regardless of whose network you're in. I ran into that problem. I got sent to a cardiologist by my direct primary care doctor, who sent me to a cardiac specialist to get an ablation. They wouldn't let me get the ablation until I got a referral from my primary care doctor. And it didn't count that it was my DPC doctor. It had to be somewhere in network. So I had to go to a Soviet bloc fee-for-service primary care office to get a referral for an appointment that happened a month ago. Texas is a special place, right? Deep in the heart of Texas, we have all of these great freedoms, except you're not allowed to dispense. I would say this, in Texas, I think we got almost to the finish line with this in the last session. Unfortunately, Texas only meets, or fortunately, depending on what your perspective is, their legislature only meets every other year. We're working really hard to make sure that this is at the top of the agenda. We have support from all the major medical associations. There's been a deal on the table. In Texas, peds have to do all the vaccinations up to 13, I think it is. And under that, you can't go to a pharmacy. So maybe it might not be a bad idea if there can be some pediatric vaccinations in a pharmacy, but what would the trade for that be? Maybe we can allow dispensing of regular meds to happen in your doctor's office so that you can take the meds home, cash pay for half the price of your copay of your medication. By the way, there's lots of pharmacy deserts all over the place in Texas where you have to drive 20, 40, 60 miles to get to the nearest pharmacy. And these aren't just in the super rural areas anymore. I mean, they're in the suburbs, exurbs. I think it's an issue it is an issue we're working really hard on. The Texas Academy of Family Physicians is dedicated to this. But come see me afterwards. We'll get you involved in that fight. There will definitely be a hearing, I can guarantee you that. We're gonna wanna have DPC docs talk about how it's done. And we do have a program, DPCRX, that will help you with that. And I would say that the idea of getting into this program is that everything would be completely compliant with the state if you do it in this manner where it's sort of prepackaged meds. There are some new rules coming online about that would probably require some additional tracking and tracing regulations under some new federal laws that are coming online this year. But we have ways that you can do that and get into the dispensing side of primary care without having to worry a lot about that. So I think we've got a game plan for that. I feel pretty bullish about getting this done this year, and moving on to a couple of other states. It's Massachusetts really is the other one where we have a significant problem.
And this dovetails in our last minute. Just a reminder, we're going to be in the back, so if you want to ask more questions, feel free to find us. But your other part of the question, how do you get involved? What I love about, it's dpcare.org, what I love about us coming together is Jay and Garrison and the DPC Coalition help figure out what is your story, how can we amplify that? So my challenge to everybody is go to dpcare.org and share your story and say, hey, this is what is so frustrating for me. It's causing me all of these fears. I can't leave corporate medicine because of. And that is a place to, on the national level, figure out, as a coalition, is there somebody who could help you or guide you or create a policy to fix that problem? So thank you so much. We have finished on time, Ashley. Look at that.
Look at that, right at the 00.